Hi, everyone. Hope everyone's doing well. Welcome to Dinner with Friends. I'm your moderator, Rachel Deer with DKB Med. Thank you so much for joining us this evening. We're excited to bring you this very important webinar today where we're going to talk about how you can talk about sex and other topics with your doctor, particularly if you're in the LGBTQ plus community. We've got both clinicians and those in the community, some who you might actually know. So at this time, I'd like to introduce our presenters. So I will ask Dr. Agwu, Justin, Deja, and Fidel to turn on their cameras. We had planned on having our colleague Marvin present as well, but he had something come up. So hopefully he'll be able to join us. If not, I do thank everyone else for being here. So Justin, I will start with you. Why don't you tell us a little bit about yourself?
Should have been prepared, but I thought Allison finally had a name ahead of me in the alphabet. So my name is Justin. I'm a nurse. I'm an HIV nurse by training. I am an addiction nurse by necessity. I work over at Boston Medical Center. And I've done everything from like street outreach, like outside at clubs, doing testing and needle exchange, to like level 4 inpatient ICU level care in the hospital. I've worked in the emergency room. What I'm telling you is I get around. And I love all the work that I do. And I've worked in an HIV clinic for a bit, and I'm really excited to be here today to talk about PrEP and all the fabulous things that go with that.
All right.
Sure. So I'm Allison Agwu. I am actually both adult and pediatric trained, which means I always say I take care of patients from the cradle and I try to prevent the grave, literally. Infectious diseases is my whole umbrella, but I really do focus on HIV. That's my passion, and particularly taking care of the young people. I really love working with adolescents and young adults, and I direct our medical program. It's a pediatric adolescent HIV/AIDS program, but I also take care of, I'm the medical director for our Access and Care Early Clinic, which is a young person focused clinic on the adult side. I do everything from general infectious diseases to PrEP to HIV care, et cetera, et cetera, et cetera. And so I'm really excited to be here and talk about sex. My kids call me a sex therapist. I don't like that, but that's what they've named me. Really
Thanks, Dr. Agwu. And Deja, why don't you introduce yourself?
Good. Hello, everyone. Good evening. Good afternoon. My name is Deja Cabrera. My pronouns are she, her, hers. I am from San Diego, California. I am an empowered transgender Latina. I work in the HIV field. I am a community health educator and advocate, which means I do HIV testing, PrEP navigation, PEP navigation. I call it a sexpert, Dr. Agwu. That might be another term, but sexpert or sexual health diva. So I'm excited to be here and to have this conversation. Thank you for having me.
All right, and Fidel.
Hey everyone, my name is Fidel Martinez. I use he, him, his pronouns. I'm actually currently a college student at Columbia University in New York City. I'm originally from Texas, so I've had very different experiences surrounding sexual health, surrounding taking PrEP, and even just like the whole LGBTQ scene in general. So I'm really excited to come here and talk about my experience.
Okay, well, thank you guys. And thank you for everyone who's joining us tonight. I'm seeing people trickle in, which is great. So again, here's our faculty. They just introduced themselves, and here are their disclosures. And I just like to say this educational activity is supported by an independent education grant from Gilead Sciences, although all activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are the topics we're going to be covering. So we're going to be talking about the HIV landscape, testing, PrEP, barriers to PrEP. We'll have a panel discussion.
So I'm tasked with talking about the landscape of HIV, and Justin, our deal is to go through these, but not to spend too much time, because I think the richness is in the dialogue and the discussion that happens. So go ahead, landscape of HIV, and next slide. So as you know, you may or may not know, there's a whole initiative to end the HIV epidemic. And this is announced by the last administration, February 2019, and it's called the Ending the Epidemic Initiative, which is a goal of reducing HIV infections by 75% by 2025, 90% by 2030. Every year, there remains about 40 to 45,000 individuals in the US who acquire HIV. And so the goal is to try to minimize that. And the ways to do that is to, of course, to protect yourself and others, and we'll talk specifically about that. And then getting screened. And so getting screened means getting tested. And if positive, and this is a sort of a next sex neutral approach, right? If you're positive, starting treatment and staying in care, where we have that U equals U, undetectable equal untransmittable, where you're unlikely to pass the virus to anybody else. But if negative, we used to say, okay, we'll see you next time you get tested. Instead, we should say if you're negative, use condoms, but also consider PrEP, right? So pre-exposure prophylaxis, which we'll talk a bit more about, and continue routine testing while doing it. Next slide. So HIV diagnosis by age. So I think the large majority of you were in the 25 to 34 age range. And as you see, about 40% of individuals who acquire HIV, and this is 2019, last year we have data, were in this 25 to 34 year age range, with about 1 in 5 being 13 to 24. But still, even to the 55 plus, they're having sex in those senior retirement centers, et cetera, so that there's no age group that escapes new diagnosis. But the population, the group that's on this call, is in the highest risk category where we see most infections. So I'm really glad that you're here to talk more about it. Next slide. When we look at HIV diagnosis by race, some statistics a few years ago came out that 1 in 2 African-American males who identify as MSM would acquire HIV in a lifetime, which is a scary statistic and part of what got me activated to start talking more about PrEP, et cetera. So there's a huge disparities in race. So about 12% of the population is African-American, while 42% of new diagnoses are in African-Americans or Black individuals, and also disparities by Hispanic, Latino, and going down compared to the white.
Oh,
I think
I'm just going to mute you, sir. Yeah, just a reminder. If you could, everyone can mute themselves. That would be great. But when we get to the Q&A, we would like you to come off mute and ask your questions.
Definitely. And again, please, Deja, Justin, everybody, please jump in. If there's anything I say triggers you or you want to jump in, Fidel too, just please go ahead and do so. Next slide. So diagnoses by transmission, again, another story of disparities. When you look at the individuals who acquired HIV in 2019, what you see is, one, we have more males who acquire, and of those males, large majority are identified as same gender loving or male to male sexual contact. But you see, again, risk in all categories, heterosexual females, and then African-American females when you look at that, but really the predominance are among men who have sex. Next slide.
I actually had a question.
Sure.
Before we move on, Deja, can you kind of talk about the stigma you face being transgender and maybe your healthcare provider not knowing which box to check here?
Yeah, so far we've been seeing data on age and race, but we haven't seen it broken down into gender, not just transgender individuals, but women as well, women who are diagnosed with HIV. And for myself, being a transgender woman, the stigma that I face is that I'm already diagnosed with HIV. And the truth is that I'm a trans woman on PrEP, and being a PrEP advocate and helping folks navigate to PrEP. And for me, I look like my community, and the community that's most vulnerable to HIV, which are trans women. And so for me, the stigma that I face is just being able to have the guts to walk into my doctor's office and say, hey, I need some PrEP for HIV prevention. Once I say that, the assumption is that I do sex work. And then I have to kind of gear that conversation away to where it's just, let's talk about where I just want to protect myself. We don't need to talk about any personal things other than me getting on PrEP and preventing HIV.
Deja, thank you so much for bringing that up. I remember you said that last time, and it is. I think we had over, 80% of the people respond to the poll said that they have felt their doctor judge them or something when they walk in. making assumptions, and that does impact how people engage in care. So thank you for sharing that. Would love you all to also add your thoughts in the chat and when we talk about in the Q&A, because that's what we're trying to one, disarm that madness, but also then empower people to move past it and to feel free to call people out if they feel like that's what's happening. Next slide. Yes. So, this is the estimated, I always tickle when I get this slide because people sit there and try to calculate, well, I had this many sex acts. This is sort of a general slide that just talks about the probability of acquiring HIV by what you do, right? So blood transfusion, we know, because we learned that early in the epidemic, if you get a blood transfusion from somebody who's positive, your risk of acquiring HIV is exceedingly high. Close to that, though, is needle sharing, or particularly with someone who's positive, where risk for if you do it 10,000 times, 63 times out of that, you potentially acquire HIV. Less from a needle stick. We're talking more about sexual acts, and certainly when we talk about sexual risk and talking to patients and in shared decision making, what do you need, how do we protect, etc. I ask about, and your doctor should be able to ask, and you should be able to share. You top, do you bottom, you verse, because that helps you. These are the reasons why people should be asking, not just to be in your business, but this is why they're asking, to kind of assess what your risk is. So if you're a bottom, your risk of acquiring HIV from a partner who's positive is higher than if you're a top. That doesn't mean you have no risk as a top. There definitely is risk, but as a bottom, you are higher risk. And so this is sort of how it goes. If you're licking and biting and other things, that's okay, but you're less likely to get HIV from that way, right? So oral less likely than other things. So just to kind of put it in perspective, and when people are asking you questions, it's not just being voyeuristic, but it's really trying to tease out what your risks are and then how they should be, how to then identify what may be the best tools for you. Okay. We'll get to that, throwing body fluids. So, it's spurting or different things and what those risks are. Again, going to be less than some of the other tools, but yes, thank you for putting that. We'll address that in the Q&A. So this is what you call the continuum of care. And this is more for what happens when individuals are positive and what should happen, right? It should be you get tested, you get diagnosed, you get into care, you stay in care, and your goal is to be what you call virally suppressed, right? So you take your HIV medicine, which is usually a pill, but now there's other options that are available. And the goal is to decrease the amount of HIV that's in your blood and in your bodily fluids to decrease your risk of transmission. We don't know there are many barriers to people to getting in care and staying in care. And what we see is about half of individuals who are positive are actually in care and virally suppressed. And so that's an opportunity to, having those discussions with people, prospective partners, et cetera, about where they are in terms of their not just saying I'm on medicines, but are you virally suppressed, right? What's your viral load in order to talk about what that risk of transmission. Next slide. All right, to you, Justin.
So I get the really fun part about talking about who to screen for HIV. And so I like to start this section with a story about my mom, because, I have an unhealthy relationship with my mother. And so one of the things that she got her first HIV test like in her 50s. And she was like, should I do this? And I was like, yeah. And then she's like, why am I nervous? I was like, I don't know. You've been married to dad for like 30 years. That's weird. Right. And so I think one of the things to just recognize is people get nervous because they don't know. Right? Whether you have a lot of risk or you have no risk, it's still a nerve-wracking test if you've never had it before. And so who should be screened for HIV? Everybody 13 to 64. I would make the case that people older than 64 should be tested too, and people younger than 13, because I know what I was up to. And so I think really anybody who's sexually active should be screened for HIV at least once, and more frequently if they continue to have risk, right? And when we think about people who are higher risk, and so those are folks who are engaging in more sex, right? Who are engaging in injection drug use, who are engaging in sex that may put them in elevated risk based on what Dr. Agwu sort of her chart showed us. Those are the folks we should be testing more frequently to make sure that we are A, catching stuff early so we can treat it early, or B, helping reduce the risk to the community if someone should acquire HIV for some reason. Next slide.
Justin, can I just add something to that just real quickly? And I think one of the things I always say, I've asked in a room, raise your hand if you're having risky sex, and nobody raises their hand, right? Because risk is always something more than you do. So you could have one partner, but you're having that sex with that partner in Baltimore, where I hail. And there's just a higher incidence of HIV in Baltimore. And so it's where you're having sex, it's who you're having, it's all of it. And so that's why there's a sort of routine testing recommendation that we should know.
Yeah, and I think someone put in the chat, the language of risky sex is stigmatizing too. Yeah, and so when I talk about risk, I often talk about people understanding what risks are. So I actually go over the slide that Dr. Agwu had, and I'm like, listen, these are all the things you can do. This is the associated risk. You get to make decisions about what you want to do. And then I really do. I have some patients who say, I want to be tested once a month because that's what makes me feel safe. And I'm like, okay, cool, we'll do that. Right. And so I think really having an open conversation and dialogue is really important. Next slide. So I come at HIV prevention and care from what I consider an HIV neutral standpoint. Right. So I really think somebody's saying that the high risk homosexual sex, there's actually other codes we can use. We just got to teach your provider about that. I usually say risk for HIV exposure. That's also an ICD-10 code. Anyways, so when we're talking about the awareness of HIV in a sex neutral way, in an HIV neutral way, what we say is whether you're living with HIV or you're living without HIV, what we can do is we can protect your status and we can keep you and whoever you love safe. And so if we go to the next sort of animation here, what you're going to see is linked transmissions occur in people who are unaware of their infection. Right? We need to get rid of this like sort of nefarious claim that people like living with HIV are the reason this epidemic has gone on. That's not the case, right? People who are living with HIV and are taking their medicines, they're doing their part in stemming the tide of this epidemic, right? The same way that somebody who is HIV negative and taking PrEP is helping that way too. And so what we see here is the large majority of newly acquired HIV is related to people who are unaware of their infection or who are not engaged in care. And I want to make a very clear point here that when we talk about people who are not engaged in care, I consider that a failure of the system. I do not consider that a failure on any of my patients. It's because our system is not set up to take care of the most vulnerable people that we see, right? So if you come into the office and somebody calls you the wrong name or treats you poorly because you have a history of injection drug use, you're not coming back, right? Whether I'm the nicest nurse in the entire world, if that front desk person was mean to you, I'm lost, right? Like I'm out, I got nothing. And so I think really and truly what this slide tells me is that we do a really good job of getting people virally suppressed and keeping them virally suppressed to protect the people that they love and choose to have sex with. We'll go to the next slide. And so when we're talking about testing for HIV, I get questions all the time about what's the right test for somebody. The right test is whatever test somebody's willing to take. And I'm willing to die on this hill. Okay. And so there are really fancy tests where we can draw blood and we can detect HIV within 7 days of exposure. That's fabulous. It's called a P24 antigen test. That's really what we consider the gold standard. But if you're somebody who like injects drugs and has no veins, I'll take a rapid, we'll prick your finger, we'll put a little thing in your mouth. That's cool too. So long as you want to get the test, let's do a test that's going to give you more information about your healthcare. And while the rapid test might miss recent infection or acute infection, what it is doing is it's giving somebody autonomy over their own decisions and their own healthcare choices. And I think that's really, really important. And if we think that somebody has acute symptoms of HIV, so they have like an unexplained flu-like illness, GI upset, we might just choose to do a viral load. And I have done this in my career. I've actually done both tests at the same time, just to be on the safe side. And I think Dr. Agwu is shaking her head. She's done that too. And I think we're in the camp of better safe than sorry. We want to keep people safe as quickly as possible. Deja, you want to jump in here too?
I just had a question about like the new like testing at home HIV kits. Like how effective are they? Do you recommend them? How quickly do we get results?
Yeah, so I think at-home testing kits are great for people who are super, super private and super concerned about having to go to an office. Now, what I will say is, having diagnosed lots of people with HIV, I think sitting in an office with me and getting that news is way better than being at home by yourself. And so if you are going to do an at-home HIV test, have a buddy, at least one person that you know and trust and love who can be there with you in case the result comes back a little differently than you expected. They all do have systems in place to keep people safe when the nurse calls them on the phone with those results. But it's also it's big news, right? And so I think any kind of big news, I would always have a buddy. And I think lots of times I do testing, right, on vans outside of gay clubs or on vans outside of like gay vacation destinations. I let people get tested as couples. I let people get tested as groups because I think part of it is alleviating that stress that you have to do this alone. Nobody has to do this alone. Even though it's a test that I have to like put a needle in your arm, you can have someone hold your hand and we can do them next. So great question. I think that they're efficacious. And I think that for some people, they're the only way we're going to get them tested, and I'm down. Dr. Agwu, do you have thoughts too?
Yeah, no, I agree. I think, the numbers I oftentimes quote is they're greater than 90% sensitive. So they're not going to be as sensitive as the what do you say, the gold standard, the antigen antibody test. But if someone's not going to come in, they're not going to, then I rather you get a test. The idea is just to get the results. I completely agree with you. And definitely getting support around that to make sure, because it's, it is life changing, right? So having some support around that is important. But if any test, right, just know your steps.
Next slide. And so we're going to talk about PrEP. And I think one of the important things that I want to talk about with PrEP is when my patients come in for an HIV test, usually what I say is, so we're probably going to start you on one pill once a day after this test. I'm not sure which pill yet. It's probably either going to be a little blue pill or a little red pill, but we're probably going to start you on one pill once a day. How's that sound with you? And so if folks get the little blue pill, I know it sounds like the Matrix. I swear it's not. It's PrEP is the little blue pill, right? So it's pre-exposure prophylaxis for HIV. It's a daily pill people can use, and they can take the pill every single day, and they won't acquire HIV so long as they're taking the pill. And when I say, that's a declarative statement that I just made, right? And what I have is a lot of real world data. If we go to the next slide, is a lot of real world data about who should be offered PrEP and how we know it works in these populations. And we've done lots of studies. We've done studies in people who inject drugs. We've done studies in men who have sex with men. We've done studies in trans folks. We've done studies in women. And what we know is that if people are taking the medicine, it's going to protect them against HIV, right? Now, I think one of the issues is, how do you get someone to offer you this? Or, one of the scenarios we see all the time is you come into the doctor and you say, hey, I want PrEP. And the doctor goes, why? Don't you use condoms? Okay, not helpful. What is wrong with you? I don't know, Fidel, do you want to jump in here too? Or Deja, either one of you jump in about like what that experience might have been like?
Yeah, of course, I've been through a lot of stuff in Texas, but obviously, like I mentioned earlier at the very beginning, I did grow up in Texas, and the scene there is very different, especially, I'm sure it's a little better now, and I haven't been in a while, I have no idea what it's like. But back when I was there and I was still seeing doctors, especially with my mom, it was very much awkward when the doctor was like talking to me about this stuff, because like he didn't really bring up anything. He would like kind of actively avoid the topic of sex, and not even in just like oh, your mom's in the room way, like very much like abstinence, like you shouldn't be having sex, period. And I couldn't even imagine having brought up like having sex with men or any sort of like relations with men. So it was just this weird like feeling where it's like, yes, I'm here, I'm in the doctor's office with a person who should be able to help me with all of my questions and like make sure that I am safe with what I'm doing. But it was very much not that. And I just sat there and I was like, I can't actually talk to this person in front of me. I just have to basically lie to them and be like, yeah, like I don't do anything. I'm just here living life. No sex, no anything. And of course, like PrEP was never even brought into the question. I didn't know about PrEP until I came to New York. So, it was just not even, my doctor didn't even talk to me about condoms. So like, I didn't know anything.
And I think one of the things that I really think about with even everything you're discussing is this list is who should be offered PrEP, but it really is who needs to ask for PrEP, because there are so many providers who are nervous to talk about sex with their patients. Right? Like you have the two of us who are like, sure, what do you want to hear about? Like, what do you want to talk about? But there are a lot of doctors who get really uncomfortable when you bring up the topic of sex. So I think your point is well taken, Fidel, that it wasn't even on the table for you to ask about.
Yeah.
Right? Rachel, do you want to go to the next slide? And so the two medications for PrEP are Truvada and Descovy. Truvada is now also available as a generic. So you may see it as tenofovir disoproxyl fumarate and emtricitabine. Yes, I can say it. Isn't that impressive? I'm impressed with myself. And then the other one is tenofovir alafenamide and emtricitabine. Now, what we know about these two drugs, Truvada has been around for longer, since 2012. It's approved for anybody with risk for HIV, so injection drug users, people who have men who have sex with men, trans women, trans men, and the generic is available. And most of the time, folks are getting the generic now. With tenofovir alafenamide and emtricitabine, it's been approved since 2019. And it was approved to treat HIV as well. Both of these drugs were approved to treat HIV. And tenofovir alafenamide is just a smaller dose of the tenofovir, essentially, that gets inside the cell a little bit better. And so for that reason, the smaller pill, and it's a little bit safer for your kidneys and bones. But, this is the big but, they didn't study this one in women or people who have vaginal sex. Okay, so that's just important for you to know. They did study it for HIV treatment, but not for HIV prevention. And so this was only approved FDA-wise for trans women and men who have sex with men, currently. That's the big asterisk, currently. That might change. Stay tuned. Next slide. And when we talk about eligibility for PrEP, we really want to make sure that people have a negative HIV test before they actually start pre-exposure prophylaxis. We want to make sure they have no signs or symptoms of acute HIV. We want to document their hepatitis B status. That doesn't mean that they can't get PrEP if they have Hep B. And we want to make sure they have good kidney function. We want to check their kidney function to make sure those kidneys are working well. Next slide. And the people who should not be prescribed PrEP, really anybody with renal disease, so severe renal disease, and people who are already living with HIV. And the reason why we don't want people living with HIV to be on PrEP is because it just wouldn't be it would not be an effective treatment to suppress their viral load. So we would want them on some other agent that would really make their viral load go down. Next slide. And so does PrEP work? This is a question that was in the chat a little bit earlier. PrEP is 99% effective in preventing HIV from sexual exposure when taken daily, but it does take some time to start working. So for the old school Truvada, 7 days for anal sex, 20 days for vaginal sex. PrEP does not protect against other STIs or pregnancy, and it may be used in people who are pregnant. And so we do often see people who are pregnant start PrEP because they didn't know that their partner was doing something or because they didn't know about the status of the partner. So I think this is really important for everybody to know that there is a little bit of a lead-in time. And for folks who are having vaginal sex, there is a longer lead-in time because it just doesn't penetrate vaginal tissue as well as it penetrates rectal tissue. I know I've just used the word penetrate way too many times in a row, but that is sort of why we're seeing that disparate, the difference in how long it takes to be effective. Next slide. So what are the side effects? The side effects, short term, some folks feel nauseous for the first 1 to 2 weeks. Some folks will report a headache. Some folks on Descovy may gain 1 or 2 pounds in the first 6 months. Long term, there is a slight risk of Truvada causing some kidney problems and lowering bone density. It's really unclear if there's any clinical problems that are associated with that bone density. Like, am I going to have worse osteoporosis because I take Truvada? We don't know that. We don't think so. But we do know it lowers bone density. Next slide. And what do I have to do when I'm on it? Well, take it. That's like the big thing. That's like the numero uno thing. And we know from COVID that actually all the other extra stuff that we do is like nice and fancy for you to come see the nurse or the physician every 3 months. But like, if you do the testing and you take your pill every day, like you're going to be okay. And so for those of you who have a better sex life since the pandemic, right, like you can just take your pill every day and get tested the way you normally would. And we can do some televisits if we have to. But we do want to check your kidney function. And we do want to continue to check for STIs and for HIV while folks are on the medicine, because we want to catch stuff and treat it early if stuff comes back positive. Next. So I'm going to pass it back to Dr. Agwu to talk about barriers to PrEP, which will then lead to our lovely panel discussion, which I know has already started in the chat, so I'm excited.
It has. And I really do want people to jump in if they have any thoughts about the barriers, because I think it's again, when we have discussions, that's, it adds to the richness of it. So I talked about the HIV care continuum earlier, just the step down from who's getting diagnosed to being virally suppressed. There's a PrEP care continuum. And, we talked about 50% of the audience here was aware of PrEP, right? Now, not all the time does that awareness of PrEP actually translate to actually talking to your provider of PrEP. We'll talk more about barriers to that. And then who uses PrEP, and then who adheres to PrEP, and that's among MSM, 99% going down at each level. And then that adherence to PrEP, that's variable. I'm so surprised. Every time I see this slide and I see 92%, I'm always like, oh, really? Because PrEP, oftentimes there's significant variability in how well people adhere to their PrEP, right? And seasons of risk and who you perceive is risky partner to have, or I have that in air quotes, and people make decisions about their PrEP off and on. So sustain and staying on PrEP can oftentimes be a challenge. And then we look at transgender women, we see, again, the step down from those who are aware to adherence to PrEP being lower. And Deja, I wonder if you can comment on some of the barriers or the things that lead to the step down. I'm looking at you because you go so vocal on all this. Any thoughts about what you think is leading to that step down before we get there?
Yeah, I think just access to medical care in general, to gender affirming care in general is really challenging. And so, if my name wasn't legally changed, the fear of getting misgendered when I go to the doctor's office, just talking about sex in general sometimes is uncomfortable. These doctors, no offense to any doctors in the room, but they're old white men, and I am a brown trans woman, and talking about sex to older people sometimes is a little uncomfortable. And so I'm not going to talk about it. And then, when I see almost, less than 30% use PrEP, again, those are probably the folks that have access to health care, and just that small percentage of trans women who, have access to employment, to housing, to gender affirming care, other things like that.
And I'm going to call SK on. I can't wait to talk in the panel. So SK is really bringing up and highlighting a really critical group. And so I want to say it's 11% of people living with HIV are trans men. I think I saw my first good study on, 900-person study on the trans masculine community in terms of risk factors, et cetera, that may increase their need for PrEP. And that was 2 years ago, right? Way into the game, showing that there's activities that may increase their risk for need for PrEP. There are needs for PrEP, but lack of discussion and stigma that these trans masculine community feel. So SK, really, I'm going to point to you when we have our panel, because I do want to hear your thoughts. Absolutely. I don't know that I've ever seen the PrEP care continuum data on that from that population. The survey was sort of more of the first one 2 years ago out of Boston, just saying there are risks that's there. People don't get asked these questions. They are marginalized, things that we know, but it was nice to actually put data to it. So thank you, SK. There isn't a continuum for trans masculine. Thank you for bringing that. I would love to hear your thoughts when we go to the next part of the discussion. Next slide. So finding a provider, and I think that's part of the battle, right? What I hear everybody saying is, I don't know who to talk to. And people I talk to, I trust they don't want to talk to me about this. Fidel's experiences in Texas or jarring every time he talks about them. And so there are some resources. I know I've pointed people to the locatorhiv.gov, use the AIDS view that literally you can put your zip code and will populate what providers that provide PrEP. And you can allow yourself to go to those areas and investigate. So this is one tool to use. It's the PrEP locator. There's some other tools to use. So they will have these resources, Rachel, to share subsequently so people can get those. Okay, perfect.
Yeah, we'll send the slides to everyone that attended.
Yes.
Yep.
Yeah.
I also just want to throw this out there that these are here, and I want to make sure people know, like, you can break up with your doctor.
Yes.
Your nurse practitioner, they probably won't leave you. You're fabulous, but like you can break up with it.
That's
you can
a good
leave.
point.
You don't have to stay. And I think sometimes patients see me or see our provider and think like they are the one who saw me first, or they're going to be upset if I go to this other person in the practice. Like, just leave them. It's who cares what they think. It's about you. And I think that needs to come across.
Yeah.
I would also add that if looking at these websites is overwhelming, look into your local LGBT center and see what resources they might have on affirming doctors, or I hate seeing LGBT friendly. I don't need you to be friendly. I need you to be affirming. I need you to know how to do your job. I need you to know how to treat me. Friendly's cute too, I guess.
No, good point. Good point. Remember, it's not one directional. It's not just your doctor interviewing. You're interviewing your doctor, and if it's not working, absolutely leave them. Okay, good point. Next slide. So in terms of the barriers, and I always say we should talk about barriers, but we should also talk about the facilitators, the things that help people stay on PrEP. And I'd love to hear thoughts about that. But we focus on the barriers. It's sort of, what is a barrier? Well, taking a medicine every day. I have 2 children, and I never took my birth control the way I was supposed to, which is why I have an IUD, because I was horrible at taking that, right? So making sure you have other options, and taking adherence to oral medication is challenging. So I think we will have long-acting PrEP, whether it's injectable, there's implantables, other ideas we'll talk about later. But adherence can be challenging. There's a PrEP stigma. Oh, you're on the blue pill? Wow, you must be, right? And that may come from within, or you may hear from others. And so there is that, and people worried about that stigma. And then I think 80% of you talked about, feeling that you're being judged. So homophobia, transphobia, that is part of it. And then lack of trust in the healthcare system. I work in a clinic in Baltimore, and many people go to that clinic, and people are concerned that, well, if they go there, they may be outed for being in that clinic looking for something and be outed. So there's lack of trust in the healthcare system in many ways. Anything anybody else want to add to this in terms of barriers? Insurance, payment, getting those labs, right? Coming for testing. Some doctors holding on in your PrEP until you come get your test, like, give me my PrEP. So there are lots of things we can add to it. And then
I would also add, I think language as well. I think when we talk about, I find a lot of folks who are Spanish speaking, who don't know how to talk about sex to their doctor, or their doctor doesn't know how to communicate that sex to them, or PrEP, or, other prevention tools.
No, really important one. Okay. All right, next slide. And we'll get to circle back, you can always add. So, and I think what we've been trying to say, watching David and her bold self, right? It's about empowering yourself and not worrying about being judged. And so being honest about how you like to have sex. It is not helpful to me as a provider if I say, how do you like to have sex? I use condoms every time. I check all the status of every. That's not true, right? If that's not what's happening. So being honest, I like to be bare. I like to be this, being honest. And so with that honesty, then we could say, well, here are the tools that will most likely keep you safe, right? And then we're talking about it. Having a not honest discussion doesn't allow us to be there. Then, your goal is to maximize your safety regardless of what your partner is doing. And I'll say that again. I have a new positive woman who was in a monogamous relationship with her partner for 6 years and just seroconverted with her HIV. So her known negative partner acquired HIV during her pregnancy, and now she's positive. So if that woman would go into her practice and say, hey, I need PrEP, someone could look at her and say, well, aren't you married? Why would you need PrEP? My thing is, you came in and asked for PrEP, I don't care. You get your PrEP, right? And this is why I would have protected her. Be proactive. If your doctor doesn't know, then you push him, her, them to know, right? They should be able to prescribe you. It's not limited to infectious disease doctors or certain doctors. And you do have a right, this is the empowerment, you do have a right to have sex the way you want to have sex, as safely as you can have sex. And that's the goal. And if you don't feel like you're getting that from your provider in your empowered space, then I completely agree. You can divorce your provider and find a provider that might be there. Anything else to add?
Yeah, I will say for that, honestly, I completely agree, the provider thing, because like I said, in Texas, talking to my provider, I was like, to this man, I will be a saint. I do nothing. I just sit in my room all day. But once I came to New York and I actually started seeing the provider here at Columbia, and we have a special, I think it's the Gay Health Advocacy Project, and we have doctors there. And, one of the first things he asked was do you have sex with men? And I was like, I've never been asked that question before by a medical professional. And immediately I said yes. And ever since then, it's we've developed this relationship, and I felt more comfortable with him. I'm very open about what I do, when I do it. If I've been more active since the last time I saw him, I've straight up asked my doctor if he can give me condoms before. I honestly, at this point, he and I are basically friends. So I think there's a big part in being comfortable around your doctor so that you can also feel comfortable with yourself and like telling your experiences.
Oh my gosh. I mean, I think that's so warming to me to hear, because you then now can ask anything and you're going to get actually the honest answer, and you trust your provider, right? You should be able, we don't even have to ask, like, do you want the magnums or the other one? Right. So we literally have that conversation. Then it's like, all right, what kind of lube? I got this one, the Glide, this. That's how you should be able to talk, because if not, you're kind of just in the dark when they're in the dark, and we haven't actually gotten anywhere. Love it. Okay. I know we're going to end soon, so let's keep going. So, Justin, you wanted to talk about, I think this is so important. We can all add to this. I think we talked about the oral prep, and I was completely honest. Please don't tell anybody I never took my birth control like I was supposed to. But it is hard to take oral medicine every day, and particularly when things change, life change. You went out, you fell asleep some ways, right? And forgot your medicine. And so the idea with this is that there are many options that are coming, right? So there's an intravaginal ring, the pivoting ring. There's implantables that are being studied that go in your arm, and you get to think about it once a year, maybe longer. They're injectable prep that you get a shot every 8 weeks, hopefully coming to a theater near you, right? There's monoclonal antibodies that are coming. So thinking about how to make things easier for people so that they can live and have sex the way they want to have and be safe, right? So very exciting as a provider to see these opportunities and options that are hopefully going to be available over the next years as we have these kinds of conversations. Any one of these excite you more? They all excite me. What about trans men? And SK, we planted this for you, so ready for you. Justin, these are mine, right? I'll just keep going. You tell me if you want to jump in. So as I said already, I preempted things in saying we just did not have a lot of data, and it's a big hole, right? Trans men often left, trans masculine individuals often have left out of the conversation, though we know, that there were risk factors for PrEP, or for HIV and other STIs, but often weren't discussed. As long as you said, oh, I don't have sex, you were turned off. So let's go to the next slide. Let's talk about what we know about trans. And yes,
Can I just jump in?
Yeah.
Can I just jump in there? So there was a study published literally last month on gender affirming hormone levels in tenofovir comparatively with people who are trans experience, trans masculine, trans feminine, and cisgender counterparts. And they did dried blood spots on everybody. And so there is a slight difference in tenofovir levels. However, they were not clinically significant, meaning it's not going to affect the efficacy of the tenofovir. And this literally is off the presses at CID last month. So, I'm
glad you brought it up, because I hadn't seen it.
Yeah, it's a brand new study. It's small. It's only 24 trans men, 24 trans women, 24 cisgender folks. But I think really important to note that because we've been screaming, people are listening. And I think it's really important to keep advocating for more of this research so that we can really say sufficiently, no, it's not going to affect your gender affirming hormone therapy, and no, it's not going to affect your PrEP either.
Right. And I think, that the conversations that need to happen around sex, because I think as a community, there's been a lot of discussion about trans women. It's, all the studies include, men, cisgender men, homosexual men, and transgender women. All the studies do that. But trans masculine individuals oftentimes are not necessarily specifically targeted and included. And so there's a lot of, I think, ignorance. I'm just going to call it that, Justin, in the medical community. What does that even entail? What does sex look like? Yes, I see SK chiming in. Yes, there's not, what does that look like? People make a lot of assumptions. And as a result, they don't even think about the potential risk and where PrEP may go in. So I think as we beat the drum in terms of what we need data, 11 to 15% of individuals living with HIV of the trans population are trans masculine individuals. And so we've got to have that information. So it's nice to hear about that study, and hope there's more data that continues to evolve. Next slide. So we talked about one of the barriers potentially being financial. Most insurance plans, given the change in some of the guidelines a few years ago, I think it's the primary care service, I forget the name of it, but talked about PrEP being something that's really important. I missed, you correct me, Justin.
United States Preventative Task Force.
Thank you, Preventative Task Force. I see USPHSP, but they put that out as a recommendation. And so insurance, Medicaid can cover PrEP. The drug companies have assistance programs. Oftentimes it's the labs and other things that could end up being of some cost. But the reality is we probably do more labs than we need to do in terms of lots of things. And so how we can manage that. But I don't want anybody to think that the finances or the monitoring should keep them from PrEP. I say that again for the people in the back. Finances, et cetera, should not be a barrier to PrEP. There should be an app for that. Next slide. So panel discussion, and some of you may feel comfortable taking your cameras off and talking. That's fine. If you don't, that's okay too. You're okay unmuting. However you want to, do that. We are happy to take it, but really looking forward to people chiming in. SK, I'm gonna point you out, pull you up. I know what you said. So do chat and feel free to jump in.
Panel discussion. One question that I actually had for Deja. So can you talk to us a little bit about how you approached PrEP with your healthcare provider, or did he or she recommend it for you?
Yeah, so I started hearing about PrEP in 2014, and it had just came out. It got approved I believe in 2012. And so when I heard about it with my girlfriends, it was, mostly white gay men were taking it. And none of us had insurance. We were just all these, trans girls just trying to figure out life and transition, and hormones was mostly on our mind, and we could have access to that black market. So we figured that sooner or later pill would be at our hands black market. That didn't happen. It took a very long time. So when I left Vegas, I ended up moving back to California, and I started my transition. And just talking about hormones, the conversation immediately went into reproductive health, and preserving my reproductive organs and whatever that may cause and all of that. So there wasn't a big conversation around HIV, or the conversation about sex we were having was about me reproducing and having a family. So when I moved to San Diego is actually when I started PrEP, and it was because there was a study at UCSD specifically for trans women on hormones. They were going to pay me to take this pill. It was going to be free. So it was I'm getting this medicine for free. They're going to pay me. I'm helping the community because there's not a lot of studies on trans women and PrEP. So let me do my part. Let me collect this coin. Let me get on this pill and have some fun. And that's what I did. And it was February 7th, 2018. And it was 1 week later because it was Valentine's Day, and it was on and popping.
Awesome. Thank you, Deja. Dr. Agwu, anything in the chat? Anything from SK? Thank you so much for your comments. Anything that you wanted to address in there?
So I think we let me scroll back up. I think we were trying to address things as we got into the chat. I think there were some other resources for trans organizations sharing information, which we appreciate. I think there was some good feedback on the language about risky behavior or risky sex, and I think worth for us to make sure that we're also not stigmatizing by saying that. So if I apologize if I use that word risk. I think the CDC puts in having high risk sex, and every time that I go to a panel, I bang on the table. So hopefully we didn't do that as well. I didn't see anything else. Did I miss anything? You see anything, no. Justin?
Dr. Agwu, I like to use the word vulnerable, folks that are most vulnerable to HIV.
Yeah. So there's a good question talking about missed doses on PrEP and how much tolerance is there for a few missed pills. That's an excellent question, and feel free to jump in. Certainly we know, and when you look at the studies, the higher your adherence is, the better your protection is. So I think the goal will be to be at 100%. But really, I would say if you get to 4 to 5 times per week, you're probably okay. Don't tell anybody I said that, but the goal really should be to be at 100%. There are some new strategies that are not approved in the US where you can do sort of directed PrEP. So around when you're going to have coitus or sex, 2 before, 1 after, and 1 after, which are a little bit more burdensome. So I think the goal will be, if you say take 100% and people get to 95, that's okay. But really aiming to be at 100%. It's a great question. Anybody want to add to that?
Yeah, people are going to miss doses. Like that is going to happen, and the
Right.
world is not going to end. And you are not going to, like, it's not like you had sex 5 days ago and then you missed your dose today, and oh my God, it's the world. Like, deep breaths. We will all get through this together. When did you realize you missed your dose? How many doses have you missed? I think most of the time when people realize they missed doses, it's because a lot of stuff was going on in their life. They probably weren't having sex. And so if you miss a dose, particularly in the setting of not having had sex for 5 or 6 days, we're okay. And so I think I do want to just say that there is, I think, more leeway if you're having anal sex with missed doses than if you're having other types of sex with missed doses, because we know that it penetrates rectal tissue a little bit better than other tissues. So that's sort of what I usually tell my patients, just as a tidbit.
And I
don't know
do
if you
always,
agree with me.
yeah, no, I think I was gonna say, I do always in this conversation, because the goal is not to sit here and say life doesn't happen, right? Life happens. You forgot your pills, you went on vacation, things happen. But that's part of the importance of having the transparency with your doctor, because let's say you were on your prep and then you missed a week or two and then you had an encounter and you're concerned, and that's when conversations about PEP or non-occupational post-exposure prophylaxis. So there's ways to then add medicine just in case you had an exposure to address that, and that's like a month supply of medication. So we just to say it happens, the goal to be as adherent as possible, but they're being honest about what's happening is really critical to how to then.
And I will just say, I think we underutilize PEP. For those of you who don't know what PEP is post-exposure prophylaxis. So I have patients who are like, nah, I don't need your PrEP. I like have a partner, I use condoms. I'm like, okay, cool. But like if you break up and you have like an oopsie, I want you to call me. We're going to send the PEP directly to your pharmacy. You don't even have to see me. Just page me, call me. You'll get the prescription at your pharmacy. Then we'll talk about PrEP again in a month, right? Because I think having that low barrier access to PEP in California, y'all can just like go to the pharmacy and get it. That's brilliant, right? I wish we had that in Massachusetts, but I think that PEP is an underutilized resource for folks who are on the fence about PrEP.
There's a question in the chat about, let's see, I have a question. It's advised to start testing at 13. So what is the general developmentally appropriate age in which we should be pushing for sex ed awareness around STIs, HIV? I'm asking for a nonprofit. So thank you for the question. Sexual health in this country is truly problematic, right? I think sexual education and sexual health education begins at birth. Okay, it begins at birth. And so it's about how we talk about our organs. Instead of your TT and your cuckoo and whatever names we like to call things, it is your vagina and your penis. And it's okay to touch this if you feel good. It's not okay for someone else. Like, we need to have those conversations early. I haven't had the unfortunate experience of going to and being the sex ed person. I'm in my child's 5th grade class, and her telling me all about the sperm hit the egg and there's a fertilization. And then asking, well, how did the sperm hit the egg? And her not be able to tell me that there was actually a key and a lock, and something went in a key and a lock, and having them say, well, where are keys? What are keys and what are locks? And watching the 5th graders blow their mind and all the dinner conversation. So the answer is, it's as early as possible. We should be doing that at age appropriate levels from birth. Anything to add to that?
Well, yeah, no, what I was going to add is there's lots of ways to talk about sex without talking.
Yes.
Like, you don't need to be like, oh my God, this is how you have rectal sex, right? Like there's lots of ways to do it. One of my favorite things to do, especially with younger folks, is, have y'all seen the T video? Anybody seen the T video? No? Okay. Y'all are going to have to go and Google this. There's a YouTube video about consent with a cup of tea. Sometimes you want a cup of tea. Sometimes you ask for a cup of tea and you change your mind. Sometimes you get the cup of tea and it's too hot, so you turn down the cup of tea. So, right, and so it goes through all these iterations about sex and consent for sex, but as a cup of tea. And so it's a really simple, easy way to get young children to talk about what is consent and what does that mean. And so it's a nice way to start to have those conversations without being like, this is what sexual assault is, kiddo, right? Like, so I think I agree with you. I'm all about the early education. I just think age appropriate early education. What does that mean?
Oh, yeah.
How do we, and I, the basic anatomy, and then like getting into like, how do you have healthy relationships?
So let me be clear. I'm saying that we need to call, I'm not saying tell your 2-year-old this is how you have active rectal sex. What I am saying though is having conversations with our young people instead of like, oh, we just cover that up, we don't talk about it. Actually, it's okay for our kids to look at their genitals and know what's there. And it's okay to tell them that's not okay for someone to touch. And no, you don't have to sit on Santa Claus's lap if you don't want to. Like, it's okay to have these conversations because all of a sudden, I will say, at the youngest person I've diagnosed with sexually acquired HIV was 11. He started having sex at 9 because he was tall and he looked great and nobody asked him to wear a condom. And so if they're having sex at 11 or 12 or whatever, and we are missing the boat and talking to them at 13, we have truly missed the boat. And we know that it's being on the LGBTQ spectrum, they have sex even earlier, right? And so what are we doing? And I didn't say in that 5th grade class, no one had ever talked about anything beyond the sperm and the egg. So what about the kids? Like, oh yeah, I like guys, so I have sperm and sperm. I have nothing to worry about. So there are age appropriate, people are dropping some in the chat. There are age appropriate things that is available to young kids. And just make it normal. And even before the kids that I see in practice or having sex, I make it a space. Anything you want to talk about? Well, Dr. Agwu, one of my breasts is bigger than the other. Let's talk about that. So when it's time for them to talk about the thing that they actually are doing, they already have a comfortable space to do it. Clearly, I'm very passionate about this. So I'd love to hear Fidel or Deja or anybody else who want to jump in about this.
I was just going to add that I think when we talk about sex, it should also be from a pleasure positive point of view, from a body positive point of view, and from a very, individual point of view as well. We're all having sex very differently. We like to have sex differently. We're having sex with different types of people, different bodies. And so it's very unique and it's very custom. And, I love me some custom, honey.
True. No, completely agree. Normalizing it too, because I think we oftentimes talk about sex in a way it's just about it's often very sterile and clinical, and we forget to say to my son actually asked me, I have an 11-year-old, well, why do people have sex? I'm like, we debated for a while, like, because it feels good, son. He's like, oh, it does, right? That's okay, right? Because if you don't tell them that, you tell them all the bad things, they find out they don't believe you. It can feel good and it should feel good, right? And then that gives you an opportunity to talk about knowing what you want and like, etc. So it's okay.
Yeah, I was gonna say, I honestly wish that I had that conversation a lot earlier. And to be honest, I've never even had that conversation with my mom or anyone in my family. It's very much even today, something we just don't talk about. And I think because of that, I definitely got myself into some situations where looking back, I'm like, I probably shouldn't have been there doing that thing at that hour, but you know what? I was there, I did it. And of course, because nobody in my family talked about it, I was like, I'm just not gonna say anything. I'm gonna keep this myself. And so I definitely think it should start from a young age, even if it's just talking about your bodies and what feels good. I wish.
Yeah, and I just encourage, I know we're a little past 8 Eastern, but thank you all for staying on. This has been really great. We do have some questions coming in. I got a direct question. So I know we're kind of shifting to the Q&A. I kind of came together. If you're, how long should someone stay on PrEP?
So I get this question all the time. I say as long as you need to, or as long as you want to. The one caveat to that, and I know Dr. Agwu has some of the similar patients that I do who are a little bit younger, and they're like, oh my God, I met the love of my life. I don't need to be on PrEP anymore. He's the one. I'm like, that's great. I don't want you to stop the medicine yet. Right? Because you're 17 and I met the one of my life 4 times that year. And so I think really just recognizing that, different folks usually the deal I make with some of my younger folks is, hey, can we do this on a every 6 month or an every year basis? We'll recheck in. You still need it? Yeah, cool. Okay, moving on. And I think sort of having that conversation, having a check-in point with your provider, so it's not forever. And it's also, if I stop, then I know as the provider, if you ever need PEP, so you stopped, but if you ever need PEP, you let me know, right? We'll get you right back on everything.
SK said, as we were going back to sex ed for younger folks, Corey Silverberg's children's books are great sex ed. So thank you for that resource. Thank you.
Not to put anyone on blast, but Dallas, you had turned on your camera. Did you have a question for us? You were like the one brave soul who put on.
Oh, there you are.
I
I
feel
know, I
like
was loving it. Like, go down.
Yeah, well, I put it on because I thought it was question and answer time. So I was going to ask that question, but it wasn't in general, like, what should we be teaching kids? I mean, I teach my kids that way. Everything you all mentioned, like, we're starting it from birth. But I was talking about from the perspective of a nonprofit organization who is not yet there, but wanting to start advocating for sex health, sex awareness, education. And so having to sell it to other people that we're ready for that and that we want that. Just like if there's any articles or information, anything that I can point to that says, look, developmentally, like, they're ready for this information, you know, so that I can show other people that may not be on the same page as me.
Good question. I will point to, are you familiar with Advocates for Youth?
No, I'll write that down.
Yeah, Advocates for Youth is an awesome organization that is really youth focused in terms of just education for youth in the schools. Their curriculum they've developed that really does consider across all spectrum from a youth lens. It's vetted by youth ambassadors, et cetera. And they've actually partnered with many schools that are using that. And that may be because they may be a good resource to point to, and they're fantastic. So good point to them in thinking about using some of their resources.
I'm gonna plug a nurse because I like can't help myself, right? So there's this fabulous nurse practitioner I just saw him present at ANAC, and so he studies how families have conversations about sex with their children, and he studies how families have conversations about sex with their gay kids, with their trans kids. What does that look like? And so they've made videos. And they're sort of all the different age spectrums. And so they start like, I think 8 to 9, and then there's 9 to 10.
Thank you, Justin.
Thanks for the question. I think it's a
Thank you,
good one.
Dallas.
Others?
Yeah, any other questions? Nope. Any final thoughts from Justin, Dr. Agwu, Fidel, Deja?
This is my one final thought. If any of you came to this talk because you were nervous to talk to somebody or you weren't sure how to talk to somebody, I'm pretty easy to Google. I'm like on the Twitter, I'm on the Google. Find me, email me. I am happy to talk to you one-on-one and figure out where somebody is in your area if you really need help with that. Even if all 60 of you call, like, that's cool, I'll figure it out. So I think just to put that out there, that we really do want people to feel comfortable. And hopefully this was a first step.
Yeah, I'm just thinking, what's the Google? I'm on the Google. No, I do a lot of webinars and talking and stuff, and this actually is my favorite forum where I engage with people, because I think sometimes you're talking to other researchers and clinicians, it is nice to talk to people and to get your thoughts. And my hope from something like this is that you then become ambassadors, right? Because that's how the word gets out. And those of you, I think there are 11% of you who are sure what PrEP is, and I hope you learned what PrEP was, and then can now each one reach one, teach one, because I actually think you're more effective at reaching those who are not quite there, right? Or who may be stuck in Texas, where Fidel was, and maybe don't get the information, right? So thank you for attending, and thank you for being engaged and vocal. Really do love doing this aspect. And Justin, you can Google him, the Google. I'm also quite reachable as well. Happy to respond and
Yeah, Fidel or Deja.
Thank you. Yeah, I would just say thanks for having me. And if you all are, interested in getting on PrEP and you're worried about having that conversation with your doctor, think about all the tools that we gave you in this webinar. And just remember that being on PrEP, you're going to feel empowered. You're going to have more confidence, and you're probably going to talk more freely and openly about sex with your friends and colleagues and those around you, and just spreading all of the knowledge and resources and information you have. And if you are nervous to talk about your doctor, talk to your friends about sex and prevention methods and things like that.
Yeah, thank you guys for coming. And I very much agree with everything that has been said. I really think that at the end of the day, like, all this talk is basically about you and your like personal health, and that should come first over anything. As long as you know you're safe about what you're doing, and obviously considering like where you guys are, but it shouldn't be super scary. You know, sex should be like totally, completely fun and like, you know, I don't know. Like these days, I'm just not worried about what I'm doing because I have like confidence with my doctor, and I know that as long as we communicate, things will be okay.
Yeah, thank you, Fidel. And everyone, I just hope that we can all wish Fidel a happy early 21st birthday. That's super exciting time, and Fidel is just awesome. Colombia, it's all great things. So it's been such a pleasure getting to know you, Fidel and Deja. We've worked together for maybe a year or so, maybe longer at this time. We've done a few other things, and Dr. Agwu over all the years. And Justin, as always, you're wonderful, and thank you so much for this great information. And if you'd like to follow us, we do have so many other programs, not just for doctors, but for people in the community as well. So follow us on Twitter and Instagram at DKBmed_ to check out future webinars and other activities. So thank you so much, everyone. I hope to see you all very soon. And that's it. Have a wonderful night.